Yeah, we are moving down from the distal femur over the proximal tibia intra-articular to the extra-articular fractures in the proximal one-third tibia. And the million-dollar question is nail or plate? And the simple answer is it depends. One simple rule is the more distal, the more nail is possible, and makes sense. And the more proximal the fracture is, a plate is gaining advantages. There are quite a number of problems with instability and alignment when you look on different locations of the tibia. Very few in the distal, very few in the mid shaft area. But when it's getting to the proximal, the tibia, the percentages increase significantly. And like with all intramedullary implants, the key step for success or failure is choosing the correct starting point. The correct starting point defines alignment, and therefore it needs to be chosen very carefully. And there is a very interesting study where the team retrogradely reamed the tibia and checked where the exit was in relation to the tibia plateau, and in 75% the exit was lateral to the condylar spike, in 25% in between the two spikes, in 0% on the medial side. And this also reflects the fact that the proximal tibia is an eccentric bone. You see it also on these arthroplasty implants, which are also designed eccentrically. And this needs taken into account when you plan your approach. Another thing is these injuries are frequently bumps from the lateral side hit by a car, and we all know when the force comes from the lateral side, we get a bending wedge with the open side on the lateral side, and this is where the fracture tends to deform. So there is a strong tendency to deform into valgus, especially if you have the bending wedge open on the lateral side, and you need to compensate this tendency with your starting point. So starting medially, there is a high risk of failure and deformity. Also, when you're palpating your tibial shaft and you palpating your edge in the anterior part of the tibia, this is not the middle of the tibia, it's the lateral part, because this is a triangular cross-section, and this needs to be taken into account when you're planning your starting point. I never understood why you need for implant 10 millimeter in diameter, why you need a 11 centimeter approach in order to insert this. If it's carefully planned according to the longitudinal axis of the shaft, then small incision and minimal dissection is sufficient, and this also pays back in terms of problems with kneeling after nailing tibia fracture. There are a couple of other approaches: suprapatellar approach, parapatellar approach, transligamentous approach. They have good initial records in terms of several studies, but I'm always wondering how the soft cartilage of the kneecap really stands these high pressures when you insert these bulky sleeves and devices. What instruments do we have for reduction? We can use distractor, collinear clamps, shank screws, and T-handle, as we just have seen it before. There are also X-fix frame concepts helpful with this clothesline technique in order to achieve a reduction and be flexible in order to adapt it to the specific needs of the current situation. Additional implants. assist tools, permanent implants, which are plates and X-fixes or cerclage wires. They all can be used in order to achieve additional stability. One of the big problems in nailing metaphyseal fractures is the discrepancy between the inner bone and the outer implant. There is a lot of space, and this diameter discrepancy leads to problems, to nail translation, to fracture translation, and also to toggling and alignment problems. And this is due to the fact that there are manufacturing tolerances between locking bolt and nail. And we can overcome this by narrowing the medullary cavity in the metaphyseal area. Here, a schematic drawing of a mechanical situation. An oblique fracture is loaded from proximal, so it's slipping off and creating shear. Shear is bad for fracture healing. And also we have limited contact area from 100 to less than 20% in this example. How do we overcome it? We narrow the space with polar screws or blocking screws. So when we now axially load it, there is no shifting anymore, no gliding anymore, and we transform the bad shear forces into good compression forces, which are good for fracture healing. And as a side effect, the contact area increases. Here's the example in the plexiglass model, and we have a number of advantages due to this simple mechanical action. Here, a clear example of a 61-year-old patient. It's almost no proximal fracture anymore, but wide medullary cavity, and we see all the problems we have related to this wide medullary cavity. That's the immediate post-operative situation. And when we compare it with the X-ray 2 weeks later, we see already the implant is shifting to the medial side inside the bone, so it's migrating away from the starting point, which is far too low, and there is no resistance inside this bone. So even sometimes later, we have these situations where we have increasing valgus situation, we have pain, we have instability, and the patient is prone to revision. Pre-op plan looks like this, more proximal starting point. In the lateral view, here is the post-operative result, and the more lateral starting point in the AP shot compared to the preoperative situation. Both this situation lead to better alignment, better stability, and in order that the nail doesn't again slip off, we block it with blocking screws or polar screws in order to not only achieve but also maintain the result of the period of fracture healing. Here's the post-operative situation 10 weeks after revision, and this led to a good time-related fracture healing. Alternatively, plates can be used, and the more proximal the fracture situations, the more a plate is advisable. We can do it in minimal invasive way. We need to pre-contour, make it sure that it fits. And here's the post-operative situation. We use the fibula as a second pillar in order to address this large defect situation and uneventful fracture healing over the time course. What does the literature say? there are many studies, but all have small numbers. There is one meta-analysis from last year's summarizing 7 studies with a total of more than 600 patients. And the quick message is intramedullary nail significantly shorter time to union and lower risk for infection, while the plate significant lower risk for malunion and postoperative compartment syndrome. So let me summarize: more proximal, so more plating, and vice versa. The nail starting point is crucial. We need to understand the pathomechanics of nailing and understand the deformity rule. Again, the deformity always goes to the proximal side of the fracture obliquity. Additional assist tools are very helpful. And as a plate, we can use locked plate, of course. MIPO technique is advisable, and the result of both device types are comparable. Thank you very much.